Today is Monday, January 20th, 2025, Spring 2025 semester. My name is Carrie. I'm a family nurse practitioner student, and I'm going to be conducting a head-to-toe assessment. I'm going to start by assessing the skin of the head, neck, face, the anterior and the posterior chest, and the abdomen. The patient's skin tone is normal for ethnicity. It is warm and is dry, smooth to the touch. It has elastic skin turgor. There is no evidence of any edema. There are no bruising, scarring, lesions, or nevi. The patient's head is normocephalic, symmetric, positioned in the midline. I'm going to palpate the scalp and the hair. The brown hair is coarse in texture, evenly distributed. No signs of any infestations. There are no masses, lesions, or depressions. Is there any tenderness?
No.
I'm going to palpate the temporal arteries for tenderness. Is there any tenderness?
No.
I'm going to palpate the lymph nodes, starting with the occipital, the postauricular, preauricular, tonsillar, submandibular, submental, posterior cervical, anterior cervical, and the supraclavicular. There are no nodules. Is there any tenderness?
No.
I want to assess the temporomandibular joint. To do that, open and close your mouth. There is no subluxation or crepitus. Is there any tenderness?
No.
I want to assess cranial nerve 5, the trigeminal nerve. To do this, I'm going to assess motor function first. Clench your jaw for me. Cranial nerve 5 motor is intact. Close your eyes. I'm going to assess the sensory function of cranial nerve. Cranial nerve 5, tell me where you feel this.
Forehead, left cheek, right cheek, chin, nose.
Cranial nerve 5 sensory is intact. I want to assess cranial nerve 7, the facial nerve. I want you to smile, frown, raise your eyebrows, puff up your cheeks, purse your lips. There is symmetry in the facial expression, so cranial nerve 7 is intact. Moving on to the ears, I want to inspect them. They are normal shape and size, normal position on the head. I'm going to palpate the pinna and the tragus. There are no masses. Is there any tenderness?
No.
I want to use my otoscope to examine the external auditory canal. On the left, the auditory canal, there's no redness, no drainage. The tympanic membrane is intact, pearly gray with no signs of bulging. For the right, external auditory canal, there is no redness, no discharge or drainage. The tympanic membrane is intact. It's pearly gray with no signs of bulging. I want to assess cranial nerve 8, the auditory nerve, first using a whisper test. I want you to cover up your right ear and repeat after me.
3B8. 3B8.
Cover up the other ear.
2B6. 2B6.
All right, I am now going to conduct the Weber test to assess for lateralization. I'm going to put the tuning fork in the middle of your head. I want you to tell me if you hear it more on one side, the other side, or both sides equally.
Both sides equally?
No lateralization is present. I'm now going to conduct the Rene test. It's going to see if air conduction is greater than bone conduction. To do this, I'm going to put the tuning fork behind your ear on the mastoid bone. When you can no longer hear it, let me know. I'll move it in front of your ear and let me know when you can no longer hear that.
Now.
Air conduction is greater than bone conduction on the left ear.
Now.
Air conduction is greater than bone conduction on the right ear. Moving on to the eyes, the eyelashes and eyebrows are present. They are symmetric. The palpebral fissures are symmetric. I'm going to examine the lower conjunctiva. It is pink. There's no redness, discharge, or lesions bilaterally. On the upper conjunctiva, they're pink. There's no redness, lesions, or discharge bilaterally. The sclera are white. I'm going to assess cranial nerve 2, the optic nerve. I'm going to use the Snellen chart to assess gross visualization. I want you to cover up your right eye and read the lowest line that you can.
DHJBS.
Cover up the other eye and do the same thing.
DHJBS.
Now uncover both eyes.
DHJBS.
The patient has 20/20 vision in both eyes and in each eye individually. I'm now going to assess for peripheral and central vision. I want you to let me know when you can see my fingers.
Now.
All right, now let me know when you tell me the fingers that I'm holding up.
1, 2, 3, 3, 2, 1.
All right, peripheral and central vision are both intact. I'm going to assess cranial nerve 3, the oculomotor nerve. First, I'm going to assess consensual and direct and consensual pupillary dilation to light using my pen light. Look straight at me. There is a direct and consensual pupillary response to light. I now want to continue to assess cranial nerve 3 for convergence and accommodation. I want you to look at the wall behind me, look at my pen light, continue focusing on my pen light. The pupils are equal, round, and reactive to light and accommodation. I now want to assess cranial nerves 3, 4, and 6, the oculomotor, the trochlear, and the abducens. I'm going to assess conjugate gaze using extraocular movement. I want you to keep your head straight and follow my pen light using only your eyes. Cranial nerves 3, 4, and 6 are intact. I want to use my ophthalmoscope to assess for red reflex and to look at the internal eye structures. On the left eye, red reflex is present. Vessels are present in the back of the eye. The optic disc is a milky yellow with sharp disc margins. On the right eye, red reflex is present. Vessels are present in the back of the eye. The optic disc is a milky yellow with sharp disc margins. Moving on to the nose. The nose is straight, position midline. Cover up one nair, breathe in and out. Other side. The nairs are both patent bilaterally. Close your eyes. I want to assess cranial nerve 1, the olfactory nerve. Tell me what you smell.
Alcohol.
Cranial nerve 1 is intact. I want to now palpate the frontal sinuses, maxillary sinuses. Is there any pressure or tenderness?
No.
All right. Moving on to the mouth. The lips are pink and moist. There's no fissures, cracking, or lesions. I want you to open your mouth for me. Patient has good dentition. The tongue, the buccal mucosa, the palate, and the gums are all moist and pink. Lift your tongue for me. The floor of the mouth is moist and pink. The salivary ducts are patent. Stick out your tongue, say ah. The posterior pharynx is moist and pink. The tonsils are grade 1. I was able to determine that cranial nerves 9 and 10, the glossopharyngeal and the vagus nerve are intact because there was symmetric rise of the soft palate and the uvula with phonation. I want to now assess cranial nerve 12, the hypoglossal nerve. I want you to stick your tongue out, go the tongue is midline, no fasciculation, so cranial nerve 12 is intact. Moving on to the neck. The trachea is at midline. I'm going to palpate the thyroid gland for nodules and tenderness. Swallow for me. There are no nodules. Is there any tenderness?
No.
I'm going to palpate the carotids one at a time. Carotid pulses are +2 bilaterally. I'm going to auscultate the carotids using the bell of my stethoscope. No bruits are noted. Moving on to the respiratory system. I'm looking for any signs of respiratory distress. There's no nasal flaring, no cyanosis, no retractions, no accessory muscle use. The patient is not tripoding and is not tachypnic. Inspecting the posterior chest, it is symmetric. There are no obvious deformities. Take a deep breath in and out. There is equal chest expansion with inspiration. I'm going to put my hands on your back, say 99 each time I move them.
99, 99, 99, 99.
Tactile fremitus is present bilaterally. I'm going to percuss in between the intercostal spaces. Resonance is noted bilaterally. And now I'm going to auscultate the posterior lung field starting above the scapula. Deep breath in and out. Also want to get these lateral lung fields, especially on this right side, making sure I'm getting the middle lobe of the right lung. Breath sounds are clear and equal bilaterally to auscultation. I'm now going to assess for consolidation. First using egophony, say E.
E, 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 E.
Now bronchophony, say 99.
99, 99, 99, 99, 99, 99.
And finally whisper pectriloquy. I want you to whisper 1, 2, 3.
1, 2, 3. 1, 2, 3. 1, 2,
Consolidation is not present. Moving to the anterior chest. Again, the anterior chest is symmetric. There are no obvious deformities. Deep breath in and out. There's equal expansion with inspiration. Say 99.
99, 99, 99.
Tactile fremitus is present bilaterally. I'm going to auscultate the anterior lung fields. Deep breath in and out. Breath sounds are clear and equal bilaterally to auscultation. And now I'm going to assess the heart, first starting with auscultating the heart tones. I'm going to assess the 5 auscultation points. The first is the aortic. That is going to be at the second intercostal space on the right sternal border. The pulmonic is the second intercostal space on the left sternal border. Erb's point is the third intercostal space on the left sternal border. The tricuspid valve is the fourth intercostal space on the left sternal border. And finally, the mitral valve is the fifth intercostal space on the left midclavicular line. I'm going to do the same thing using the bell of my stethoscope. Aortic, pulmonic, Erb's point, tricuspid, and mitral. S1 and S2 are noted at all 5 auscultation points. No additional heart tones are noted. Now I'm going to palpate for the point of maximum impulse. That's located at the fifth intercostal space on the left midclavicular line. I'm going to listen at this point for a full minute, assessing rate and rhythm. Patient has a normal rate. The heart rate, normal rhythm, the heart rate is 62 beats per minute. I'm going to have the patient lie down on at a 30 to 45 degree angle. At this angle, I'm looking for any jugular venous distension or jugular pulsations. Neither are present. I'm looking for any heaves and lifts at the PMI. None are present. I'm going to palpate for thrills at those 5 auscultation points. Again, aortic, pulmonic, Erb's, tricuspid, and mitral. No thrills are present. I'm going to put the patient in a fully recumbent position. I'm going to now auscultate again at those 5 auscultation points using the diaphragm and the bell of my stethoscope. Aortic, pulmonic, Erb's point, tricuspid, mitral, aortic, pulmonic, Erb's point, tricuspid, and mitral. S1 and S2 are noted at all 5 auscultation points. No additional heart tones are noted. I want to move on to the abdomen now. First, looking at the contour. The abdomen has a flat contour. It is symmetric. There are no obvious deformities. I want to auscultate for bruits at some of the major arteries in this area. I'm going to start with the aorta, the renal arteries, the iliac arteries, and the femoral arteries. No bruits are present. I'm now going to auscultate all 4 quadrants of the abdomen, noting vowel sounds, starting at the lower right quadrant, right lower quadrant, right upper quadrant, the left upper quadrant, and the left lower quadrant. Patient has normal active vowel sounds in all 4 quadrants. I'm going to percuss all 4 quadrants. Tympany is noted. I'm now going to palpate first using light palpation, assessing for any masses, tenderness, distension, or guarding. No masses are present. Is there any tenderness?
No.
Now I'm going to use deeper palpation. Again, there are no masses. Is there any tenderness?
No.
I want to try to palpate the liver. To do that, I want you to take a deep breath in and hold it. The liver is not palpable. Is there any tenderness?
No.
I'm going to do the same thing for the spleen. Again, take a deep breath in and hold it. The spleen is not palpable. Is there any tenderness?
No.
All right, sit here. I'm going to assess costovertebral angle tenderness. Is there any tenderness?
No.
Any tenderness?
No.
All right. I'm moving on to the musculoskeletal system. First, to do that, I want to assess the skin of the upper and the lower extremities. Again, the patient's skin tone is normal for ethnicity. It is warm, dry, smooth to the touch. It has good elastic skin turgor. There is no edema that is noted in the upper extremities or in the lower extremities. No bruising, scarring, lesions, or nevi. I want to assess the joints of the upper extremities, the shoulders, the elbows, the wrists, the hands and fingers. The joints are symmetric. There is no redness, no swelling, no deformities, no nodules, no crepitus. Is there any tenderness?
No.
All right. The patient has capillary refill that is less than 3 seconds bilaterally. The radial pulses are +2 bilaterally. I want to do some range of motion exercises, starting with the fingers. I want you to flex, extend, hyperextend, abduct, adduct, oppose the thumbs. For the wrist, I want you to flex, extend, hyperextend, radial deviate, ulnar deviate. For the elbows, rotate. For the elbows, flex, extend, hyperextend. The shoulders, flex, extend, hyperextend. Internal rotation, external rotation, abduction, adduction, circumduction. I want you to squeeze my hand. I'm assessing strength. Patient has 5 out of 5 strength bilaterally at the hands. I want you to push against me, extend against me, flex against you. There's 5 out of 5 strength bilaterally at the triceps and the biceps. I want you to abduct your shoulders against my hand, adduct them toward my hand. There's 5 out of 5 strength bilaterally at the shoulder girdle. I want to assess cranial nerve 11, the spinal accessory nerve. I'm going to see if the patient can shrug his shoulders against resistance. Shrug your shoulders up. He's able to. Cranial nerve 11 is intact. And I want to assess cerebellar coordination using rapid alternating movements. First, we're going to use serial finger opposition. Hand flip flop. Other side. Finger to finger touch. Other side. Other hand. All right, close your eyes. We're going to assess stereognosis. To do that, I want you to put your hand out. Tell me what I put in your hand.
Key.
All right. The other hand. Tell me what I put in it.
A pen.
The patient was able to correctly identify both objects put in the hands. Give me one palm. I'm going to assess graphesthesia. Tell me the number that I am writing on your hand.
3.
All right, other one.
2.
All right, the patient was able to correctly identify both numbers that were written on the hand. Close your eyes again. I want to assess light touch sensation. Tell me where you feel this.
Right arm. Left arm. Right leg. Left leg.
Patient has light touch sensation bilaterally in the upper and lower extremities. And now I'm going to assess vibratory sensation. Put your hands out on your knees. All right, and tell me where you feel this.
Right wrist. Left wrist. Right ankle. Left ankle.
All right, the patient has vibratory sensation on the upper and lower extremities bilaterally. You can open your eyes now. I'm going to assess the deep tendon reflexes, starting with the brachioradialis, the biceps, triceps. Scoot back. The patellar, the Achilles, and the Babinski. The patient has +2 reflexes on upper and lower extremities on the right side. Negative Babinski. We're going to again do the brachioradialis, the biceps, triceps, patellar, Achilles, and the Babinski. The patient has +2 reflexes on the left side on the upper and lower extremities and a negative Babinski. Now I'm going to assess the joints of the lower extremities, the hips, the knees, and the ankles and toes. The joints are symmetric. There's no redness or swelling, no nodules or deformities. There is no crepitus. Is there any tenderness?
No.
All right. I want to look at capillary refill on the toes. It's less than 3 seconds bilaterally. The posterior tibial pulses are +2 bilaterally. The dorsalis pedis pulses are +2 bilaterally. I want to do range of motion exercises, starting with the toes. I want you to flex, extend, hyperextend, abduct, adduct. I want you to plantar flex, dorsiflex, invert, evert, rotate. I want you to push down, plantar flex against my hands, dorsiflex against my hands. There's 5 out of 5 strength bilaterally at the ankles. I want you to extend your legs against me, flex them toward you. There's 5 out of 5 strength bilaterally at the knees, abduct against my hands, adduct towards my hands. 5 out of 5 strength bilaterally at the hips. Stand up, we're gonna do some range of motion exercises. Starting with the knees, we're gonna flex, extend, hyperextend, flex the hip, extend, hyperextend, abduct, adduct, circumduct, internally rotate, externally rotate. On the other side, we're gonna do the knee, flex the knee, extend the knee, hyperextend the knee, flex the hip, extend, hyperextend, abduct, adduct, circumduct, internally rotate, externally rotate. All right, I want to look at the spine of the patient. There are no abnormal curvatures. The spine is straight, it's in alignment. Is there any tenderness?
No.
I want you to bend forward at the lumbar spine, showing good lumbar flexion. There is no sign of scoliosis. You can extend that lumbar spine by standing straight up, hyperextend it backwards, stand up straight now. I want you to flex to the right, flex to the left, rotate to the right, rotate to the left. For the cervical spine, I want you to do chin to chest to flex that cervical spine. Head straight up, head back to hyperextend it. I want you to flex it to the right, flex it to the left. I want you to rotate it to the right, rotate it to the left, just twist it back and forth. All right, you can turn around. I'm going to do the Romberg test. To do that, I want you to stand feet shoulder width apart. Close your eyes, hands at your side. All right, the patient is balanced. You can open your eyes now. I'm going to do a gait assessment. I want you to walk away from me, walk toward me. Now we're gonna do a tandem gait assessment. I want you to walk away from me heel to toe, like this, tightrope walking. Turn around, walk back toward me, heel to toe, again, tandem assessment. All right, turn around, hop on one foot, hop on the other foot. All right, my head to toe assessment is complete.